Yeah.
Yeah. So it seems that we are live on YouTube. And Shilpa madam, I think today's topic is, I think, extremely important as far as probably enhancing and optimizing the IUI outcomes are concerned. And in the whole session, we are going to touch upon a lot of basic aspects, but not on semen preparation. Okay, so that is what I have been told. So Shilpa madam, you can go ahead and
Yeah, just give
start
me a
it
minute.
off.
Yeah. So I would like to take this opportunity from the team of Project Pelvis, which has been started by Dr. Jay as an educational platform. And I think time and again, the whole team of Project Pelvis has proven that the motive is only academics and nothing else. And I think in this past 11 master classes, we have had spectrum of topics which we have covered, ranging from stimulation protocols for PCOS in non-IVF setups, which I think many people have messaged me that it was very useful even in their practice, which they have found it very applicable even in rural areas where they don't have much facilities for higher ART procedures, to almost like something which is an oncofertility stimulation protocol like random start protocol, which even like I have tried to find literature where the literature was not giving much information. And by Dr. Jay's experience in doing hundreds of cases in RSP, he gave us wonderful insights. And sir has been quite selfless and committed to this whole thing to reach out to every gynecologist who can who want to learn infertility. And I think this has brought in the whole fraternity together, and we wish to take this journey with all of your blessings to more and more useful sessions for each one of you. So over to you, sir. Thank you so much. Yeah.
Call basically, which I have as a flow chart in my hospital. Okay, so I will just draw out this entire flow chart for each and every one of you. Okay, so Shilpa madam, just I just want to share the screen. Just let me know if you can hear me.
Yeah.
Okay. So can you see my screen?
Yes.
See, we are practically going to discuss IUI today. All right. And we are not going to touch so much upon the semen parameters. But I want to tell everyone that when you are doing IUI or when you are planning to do IUI, it is important that you have a good selection criteria. Okay. Keep that in mind in order practice. Okay, you can't really match this good selection criteria. I understand that. Okay, simultaneously it is important average success rate of IUI in a single cycle to if possible frequency of natural intercourse. Okay, you can't really be expecting a miracle success rate in IUI when the couple is just not having natural intercourse. So just keep that in mind. Okay, and the most important thing in IUI is stimulation. Okay, how well you stimulate in that particular cycle. Okay, Shilpa madam, is this visible? I'm not able to see any one of you.
But sound is breaking, I mean, I think there is some lag.
Okay, but can you see the screen properly?
Yes, screen is seen, but the voice is breaking in between.
Okay. So shall I continue?
Yes, please.
Okay, fine.
The screen went off.
Yeah, I think the screen went off automatically, and I don't know what happened.
No, can you please
Right.
check your internet Wi-Fi?
You want me to check my Wi-Fi?
Yeah, now it is clear, but in between there was a break. And can you please start from the beginning, what you wrote on the whiteboard?
Honestly, I don't know.
You'll have to start from the good selection criteria.
Am I audible to everyone?
Yes, yes.
Is it better now? I mean,
Yeah, it's better.
okay. So I'll go back to the screen sharing, right?
Yes.
Just Shilpa madam, just tell me if you can see the screen again.
Yeah, we can see the screen.
Okay,
Yes.
so fine. So let me just restart everything. What I was predominantly talking about is that in IUI, you need to have a good selection criteria. That is something which is important for you to understand. Second thing, please understand and remember that 12 to 15% is your average success rate. And please remember that cumulative cycles with frequency of natural intercourse is important. And the most important thing in an IUI cycle is going to be to achieve and to do very, very good stimulation. Okay. So now I'm going to be demonstrating the exact flow chart which we have in our hospital here. This is a flow chart which I have made for the nurses because a lot of stimulation in my hospital is started, initiated, managed, and mobilized by the nurses. Okay. So what are our criteria as far as IUI and how have we divided it? Okay. So the divisions are very simple. The first division is going to be for a normoresponder. I will label everything. All IUIs are going to be started on the first, second, or third day of the menses. Okay. Normoresponder is a lady who is having an antral follicle count of between 8 to 12, antral follicle count more than 12, 12 to 20. Low AMH IUI is again something which is very, very important for us. Low AMH IUI is any antral follicle count having less than 6. Okay. And this fourth, which I have written, okay, is referred. Why I'm saying this, I'll come back to it in a little while. Okay. Because referred is also something which is very, very common, which happens to us in our clinic. Okay. Just remember this as a flow chart, and I think your life, as far as IUI is concerned, would become very, very nice. Okay. So what are the female criteria which my staff will assess prior to doing IUI? Simple. They will always do an AMH of the lady. They will always look at patency of fallopian tubes. Okay. This is mandatory. They will always do a 3D ultrasound of the uterus. Okay. All this is going to be done obviously when the female is reporting or in the previous cycle, but the best time is day 2, day 3, day 4, or in the previous cycle. Okay. So I'll just write down or in the previous cycle. This is mandatory criteria. Okay. Shilpa madam, I hope you guys can see it now. Okay.
Yes, yes.
Fine. Then comes the male partner criteria. So we as a clinic mandatorily do semen analysis on CASA, that is computer assisted semen analysis. We almost always do a sperm DNA fragmentation index for IUI cycles as well. Okay. We will do a detailed assessment of morphology. Okay. And remember, your IUI will not work. So I'll write it down in a different color. Your IUI will not work very nicely when you have husband semen analysis with less than 5 million per ml counts. Along with, so I'll just add less than 10% motility. Okay. Now, I'm not saying don't do IUI for this, but I'm just telling you that in this situation, your IUI is not going to give you the most optimal outcome. But just keep that in mind, because that is something you need to counsel to your patient. Okay. What is going to be your stimulation protocol for all these patients? Okay. How to stimulate? Okay. So stimulation is something which we have standardized. I just thought I'll share with you. All right. In any and every normoresponder, it is going to be letrozole 2.5 plus HMG 150 international units, mandatorily to be given for approximately 5 to 7 days. Okay, I'll come to this a little later. In all hyper responders, okay, two protocols always, it is going to be either letrozole 2.5 mg plus HMG 150 international units for 5 to 7 days, or it is going to be extended letrozole protocol. Okay, it's mandatory. No other protocol. For all patients with low AMH, it is almost always going to be low dose HCG protocol. Okay. We have described these protocols in great detail in our previous sessions. So just remember these things, and always remember that in all these protocols, my target in IUI is very simple. I'll write down my target here. My target for stimulation is to obtain 2 to 4 good follicles. Okay, I want this. I know there are many people who are going to say, no, it has to be monofollicular, you should reduce twinning, you should do this, you should do that. I completely agree to you. Okay, I completely agree to you. But I want to specify that these are my targets. I want 2 to 4 good follicles. It's very simple. I want good outcomes out of my IUI. I do a lot of IUI, and I'm the costliest guy probably in the city as far as IUI is concerned, and I want results. Okay, fine. This I will never change my stimulation. It is always going to be this. I will justify this a little later. Why HMG along with letrozole? Remember, when you have HMG along with letrozole, what it does is it prevents, okay, it really prevents that supraphysiological E2. Okay, and because it prevents the supraphysiological E2, the advantage it offers is better synchrony with the endometrium. Okay, better synchrony with endometrium. So please keep that in mind. This is what I like to follow. Fine. Okay. Along with stimulation comes the next thing. What are your add-ons? Which other add-on drugs you are going to use? So I have told this very clearly that I like to use pre-treatment antag if at all I want to, very rarely. And I also like to use half dose antag in cases of a lag. Okay, in cases of a lag. So where is the lag? The lag is going to be between the follicle and the endometrium. Okay, in that situation, half dose antag is something which is very nice. I have taken a session on it. Anybody who wants to go through it, go through it. It will really help you. It is only for IUI cycles. Okay, then comes the most important thing. What is my trigger? Everybody knows the answer. My trigger is almost always going to be 10,000 HCG only. Okay, I don't have any other trigger as far as IUI is concerned. Okay, what is going to be my luteal phase support? Everybody knows this. I am repeating. My luteal phase support is going to be. Hello? Can you hear me now?
We can hear you.
Yeah, so my luteal phase support is always going to be a progesterone gel 8% twice in a day, which is to be given for 14 days. This is my standard for all IUI cycles. I will never change this, never ever change this. Okay. Now I will come to something which is interesting as far as IUI is concerned. We get a lot of patients who are referred from half stimulation done, follicle not growing. You know, we have given 5 days of HMG, we have given 5 days of letrozole, follicle is not growing. Patient is in India only for 25 days. Kindly help us do IUI. Okay, only in these situations, okay, on that day of referral, which is typically going to be on the 6th or the 7th day after that stimulation, okay, we would like to do an E2. Okay, we do an E2 of the patient. If the E2 of the patient is less than 50, we change the brand, and we give HMG 225 international unit stimulation alone. Okay, for IUI. Okay, just remember this. If the value of estrogen is more than 50, okay, then in that situation, we will just cancel out the cycle. We will not rescue that IUI, we will cancel out that cycle. But a lot of these patients we do, and we get excellent outcomes when we are using 225 international units of HMG in these type of situations. We have a standardized brand for HMG. I have not changed my HMG brand since the last 2 years almost. Okay, so I like to standardize. I have told this multiple times. I like to standardize. Okay, I will add one more point here. This is always there in my list for my nurses, so they will know this. What is the technique of sperm preparation? We are going to take a detailed class on this. Okay, but I'm going to tell you as well. In almost all cases, it is going to be swim up. Okay, in all the cases, it is going to be swim up. Swim up everywhere. We'll use swim up. There are people who will tell me, when will you use density gradient? Trust me, even patients who are having abnormal morphological parameters, okay, we end up using swim up. I will give you a justification of why not density gradient for all cases, and that is predominantly for standardization purposes. Okay, and the final thing which we have is adjuvants. Okay, so what adjuvants do we give in our IUI protocols, or do we give any adjuvants? Okay, so recently over the last 1 year, we have started using this product. I will write it down for you for male partners. The name of the product is resquetrol. Okay, and the criteria to give this is when DNA fragmentation index is more than 20%, or when morphology, okay, is less than 5%. Our morphology and DNA fragmentation are both studied on CASA. If that is there, we give resquetrol to the patient 1 month before starting the IUIs, and we continue it till the patient is doing 3 to 4 IUI cycles with us. I actually do not know how much it helps, but I'm sharing because this is something which we have started doing. All right. We never add estradiol valerate in order to enhance the thickness of the endometrium in the cycles. We never do all those things. We do not add sildenafil in the middle of our cycles. We do not add low molecular weight heparin in IUI cycles. But yes, we add ecosprin in quite a lot of these patients. And I think that is something which is important. So there we go. As far as the basic protocol of my entire IUI, this is the only flow chart I have in my hospital. This is the exact flow chart which I have drawn for you. And the advantage of this flow chart is it makes life for my nurses very simple. Okay, this is actually stuck at 2 places. One is in the nursing department, and second is in the IVF laboratory. Okay, so it makes life very easy, and it gives very good results. I have deliberately not included sperm preparation in this because Dr. Shilpa has told me to take a specific session on it, and I will guide you on great details on that, because once upon a time, as you know, I was an embryologist. Okay, so I know embryology and sperm preparation very well, right? So Shilpa madam, you had prepared a set of
timing you
questions.
didn't tell. Timing of IUI after the trigger.
Yeah, sorry, I forgot. The timing, I have not written that in the chart because again, we have standardized it. See, all triggers for IUI are going to go after 10 o'clock in the night. This is in my hospital. You can have a different protocol in your hospital. The day after, so like let's say today night 10 o'clock. Today we are on Thursday. Today night 10 o'clock, the patient who takes the trigger for IUI, they will report to the hospital at approximately 9 o'clock, 10 o'clock on Saturday morning. Once the husband gives sperms, so there are 2 options. Either you have frozen sperms or you have masturbated sample collection. Both will give you very good outcomes. There is no difference in that at all. Okay, so once the husband gives sperms, the total time for sperm preparation is going to be approximately 2 hours. All right, once right from the time of masturbation, getting the sample, liquefaction, swim up, incubation, okay, is going to be approximately 2 hours. So IUI will approximately be done at around 40 hours. Okay, I can't be really superb at, is it 39th hour, 40th hour, or 41st hour, but I've taken this down as an average that at around 40 hours the IUI is going to happen. Okay, and that is a very standardized thing in our hospital.
Okay, yeah, that was good. So let's start one by one. So do you do IUI in cervical factor and immunological factors? I mean, do you believe in it according to your experience?
I do it. I do it.
Okay. And in cases where the male partner is HIV positive, so what precautions you take for the IUI?
Honestly, there is no need to do a double sperm wash. So that is the first thing which I want to clear. The first important thing which you should be doing in this is to do an HIV viral load of the male partner. If the viral load of the male partner is, less than 1,000 copies, then it really doesn't matter how you prepare your sperms. Trust me. And most of these guys who are on HART will have a very, very reduced viral load. So one should not worry about it. We do HIV, HbSAg partners very, very frequently, very, very frequently. Okay. And it works very well.
Do you check for the evidence of rupture before you
No,
go ahead?
no, I don't.
Okay. And in mild endometriosis that you have operated on, so the tubo-ovarian relationship is very important for you to decide on the IUI?
Tubo-ovarian relationship in any fertility enhancing surgery is going to be very, very important in order to decide your outcomes for IUI. And if at all you are doing a diagnostic histolaparoscopy, please go ahead and do a micro assessment of the tubes. I would really like to add that we do something called as salpingoscopy and falloposcopy both in our hospital, but most of the times we end up doing a falloposcopy because we end up assessing the tubal fimbrial end of the tubes. Okay. And if the fimbrial end of the tubes is good, okay, if the fimbria are motile, I know a good appearance of the fronds does not mean that they are motile, but it usually gives you a good assurance that the patient will have some benefit. Okay. It gives you that assurance.
Okay. And do you believe in natural cycle IUI in any situations?
No.
In your center, you only do stimulated cycle IUIs, is it?
I will only do stimulated IUIs as a rule.
Okay.
Natural cycle IUI, we have only one criteria, but it is very rare. So I have not honestly written about it. There are a lot of these male partners who are going to come with very severe refractory erectile dysfunctions. Okay. Honestly, what is the test for that? You are supposed to do a vibro ejaculation. I don't know how many of you have done vibro ejaculation. It is an OT procedure. Vibro ejaculation may the husband is given sedation. He is taken in the operation theater and the vibro ejaculator is actually placed inside the rectum, close to the prostate. Okay. And the sperm, the semen which gets collected out of it is frozen. Okay. So there are some couples who are going to be insisting for all that shit. I am not a big fan of doing that, but then we have to oblige some people and we rarely do it.
Okay. So you said the criteria for you to start was that many that you said. So is AMH, AFC, do you consider it while taking into account the dosage or protocol, or is it completely standardized and you don't even...
It is one protocol. There is no difference in the IUI protocol for any of these patients, irrespective of their antral follicle count or AMH, as far as IUI is concerned.
Okay, so do you use urinary LH kit anytime in IUI cycles?
I don't use.
Okay, so do you use Doppler to trigger like PSV routine?
No, we discussed this in the last session as well. We do. I showed a video of how we give the trigger based on the Dopplers, right? We don't really end up doing the 3D AVCs. Okay, we don't do it for all the patients, but if people want to do it, it is a good value addition. That much I can tell you. Otherwise, go by the standard parameters and you will do very well as far as the Doppler is concerned.
Okay, and abstinence before IUI, what is your recommendation to your patients?
Honestly, we don't recommend any such things because if DNA fragmentation is more than 20%, all right, in that particular situation, you want the husband to have frequent masturbations before he gives you an IUI sample because you want to reduce that DNA fragmentation. That is one of the treatments, right? Yes. So we don't recommend anything like that. But we do a backup frozen sample for almost every male partner.
Okay, and do you advise sexual intercourse after IUI?
Yeah. Sexual intercourse should be advised after IUI. There should be no restrictions.
Okay. And when do you do double IUIs in your practice?
I don't do it at all.
Okay, so you have a frozen sample. Do you pool the samples in case if the count is less or if
No.
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 Okay, and how many max cycles that you advise for IUI before advising for IVF?
4 to 6 is what is written down on our consent. So right from the 4th cycle, if the 4th cycle fails, one of our boys will start counseling that now you need to do IVF, now you need to do IVF, now you need to do IVF, like that.
Okay, and procedure for the IUI, do you use Cusco speculum or do you use sim speculum with the alloys?
I use Cusco speculum, half-filled bladder, head low of around 10 degree to the patient so that the uterus becomes mid-position. Again, that is standardized. There is a chart which I can show probably. I'll have to go to the OT and just show you that chart for IUI. It is very simple. Half-filled bladder, Cusco speculum, 10 degrees head low. Okay, we have the same OT table in both the OTs. So 10 degrees head low. After that, once the Cuscos is put, try to not put any Alice Fallis. We don't use any hippies or any media or any buffered solution to clean the cervix. We will just clean it with simple, that earbud is available. No, we will just clean it with that simple earbud to take out that cervical, whatever those white mucus and all this powder is, all that is present. Once we do that, the IUI catheter will go inside. The catheter will go and perform IUI slowly. Even for 0.5 ml of aliquot, if it's okay if you take approximately 7 to 12 minutes to do that IUI, it is absolutely fine. Okay.
And what happens in severely retroverted uterus? Do you find it difficult to negotiate? How do you tackle it?
Yeah, so that is one thing which is there, and I'll share you a good secret. I never use the IUI catheter to do the IUI. Okay. Since the last 5.5 years, we have only used embryo transfer catheters to do IUIs. Okay. So the outer catheter goes at the cervical canal, and the inner catheter, which is loaded with sperms with the aliquot behind it, goes and puts the IUI sample right inside the center of the uterus. Okay. If anybody wants to enhance their success rates, believe me, your embryo transfer catheter's inner catheter is so thin, it is less than 1 millimeter in its maximum diameter. It will cause the least amount of damage to the endometrium. Okay. And usually the embryo transfer catheters are 25 times more expensive than an IUI catheter, sometimes 50 times more expensive, and they will do very, very good to the endometrium. So I use that. I charge the patients for that. It's up to people if to follow that or not.
Okay. And what about usage of misoprostol? Do you use it to dilate?
Never. There is no misoprostol in my hospital because I don't have an MTP license. So I have no misoprostol.
Okay. And what about atosiban? Do you use when you have difficult IUIs?
No, we don't use atosiban. But some people I've spoken to, they've said it is good, but I am not using it.
Okay, so duration of infertility, do you take that into consideration for decision on IUI?
That is the first line of my IUI, that it should be a good selection criteria. But in modern fertility practice, you will have patients whom you will have to accommodate after having 2 failed IVF cycles, don't have money. Male partner is 41, wife is 39. They don't have the money for the 3rd IVF, but they want to do something about it, right? So you will have situations where you have to accommodate these patients.
Okay, and below what AMH you don't even try IUI, you want to go ahead directly for IVF?
Honestly, there is people do say that don't do it for AMH less than 0.81. Okay, you might not get the best possible outcomes, but I think with low dose HMG, the good thing is, with low dose HCG protocol, we are doing IUIs for previous failed IVF cycles as well. And even with AMH 0.3, 0.4, we are doing, and outcomes are decent. I have shared it on the WhatsApp group. Obviously, it is not published, but the outcomes are very decent.
So do you give pre-treatment ocipil for any patients before IUI?
No.
And is all your IUIs done in the clean room? In the OT?
Clean room means always OT. Yeah, it's an OT procedure for us.
Okay. And do you do it as USG guided in certain situations?
Yeah, it is good to document an IUI under USG guidance. The patient feels very happy about it.
So if there is a cervical stenosis, if you are not able to negotiate for the IUI, do you do a trial or a mock sounding of the uterus on day 2, day 3?
We don't do it, madam, but there is something which is very good, which you can try in cases of cervical stenosis. Okay, you have this guide wire, which is available, which we used, which we normally use for ureteric stentings. Okay, that guide wire has a rigid end. Okay, so that rigid end you will see going inside the uterus. Okay, on Siam guidance. It is very nice. If somebody wants to follow it, it is a very nice thing to follow it. Pass the embryo transfer catheter over that. Okay, once it has gone inside the uterus, and take the guide wire out. It's superb. So I think it is superb because we have done many cases like that. It is up to the fine sense of wisdom of everybody else.
So many a times we see that there is regurgitation of this semen once we are doing the IUI. So
yeah, take 7 to 10 minutes. The regurgitation will be almost zero, honestly.
Okay. And see, as we know, like IUI is something where the egg and the sperm have to form a good embryo. And I think everybody agrees that the maternal genome is much more important than the male factor or the sperm.
Completely agreed. Completely agreed.
Yeah, in this situation, I think age is the single most important factor which determines that. So beyond what age you will not even go for IUI?
See, ideal is to not touch IUIs at age more than 40. Okay, that is ideal. Okay, but then as I said, in modern fertility practice, you may have little ups and downs. You might have to accommodate certain special people.
Okay. And what about antioxidants like coenzyme Q10? I mean, do you advise it to female
so
or
this
male?
resveratrol is an antioxidant, okay, which I just mentioned on the chart, and that is a decent one.
Okay. And in underweight women,
Yeah.
so do you find any difference in the stimulation or the say response? Do you find that they
No.
respond late? No. Okay.
No.
So you said you want 3 to 4 good follicles for you to go ahead
Yeah.
with that is your target. So is that
Yeah.
because you want one good embryo, like one top quality embryo? If we had done an IVF, I mean, is that
Yeah.
why you 3 to 4?
Yeah, almost the same extrapolation.
Yeah. So if there are more than 4, so do you abandon or do you counsel them to convert to IVF?
Very rarely, madam. With 150 international units, try giving it to 100 patients. You are going to find 1 on 100 who will have more than 4 or 5 dominant follicles which are stimulated.
Okay. And the previous response to treatment, does it change your protocol in any ways, like what standardization you have done? If the patient, usually they come to you after failed 2, 3 IUIs. So do you change on their response?
No, because the patients who are normally going to fail a lot of IUIs are on are on mono drug stimulation. Somebody will give only clomiphene citrate. Somebody does not like clomiphene. They will give only letrozole. Somebody who does not like both of them will give HMG 75 because they are worried that OHSS will happen.
Okay, so you have given half dose antag and still the endometrium lags, or if the endometrium is not very good. So at what endometrial thickness you would like to cancel the IUI? Below
Anything
1.
less than 5 millimeters.
So above 5, you still go ahead with
5 with triple line, yes, because there are so many women post COX who have completed the therapy for COX and have a wonderful patent fallopian tube. In that, it is very difficult to grow an endometrium consistently above that. That is one. Second, remember, despite good follicles, if chronically the endometrium is not growing more than 5, that can either mean that the patient has chronic thin endometrium or it is a poor quality oocyte. Okay.
Yeah.
So you really need to investigate that little thoroughly if you find it for more than 2 cycles.
Okay. And do you use parvovirus in IUIs? Have you used it?
Can't afford it, madam.
Okay. So if there is the cohort is not synchronous, if there is asynchrony in the cohort,
give pre-treatment antagonist in IUI. There is no problem.
Okay. And androgen pre-treatment, do you give it for poor responders?
No, I don't give it in IUI.
Not in IUI. Okay.
No.
So ANTAG cycle, like how we do it exactly in IVF. I mean, do you do it even for IUI?
No, we give only that half dose ANTAG if it is mandatory. Okay, remember your IUI cycle is your fresh transfer cycles of IVF. So you got to be very careful of maintaining the endometrium embryo synchrony. Okay, you have to be very careful, as a result of which we all know that a prolonged ANTAG cycle is going to reduce the endometrial receptivity. So we don't want that, honestly. Okay, simultaneously we don't want a supraphysiological E2, because a supraphysiological E2 is going to cause an abnormal LH surge. Without an ANTAG, it is very difficult to control that abnormal LH surge. The best way to control it is adding letrozole. Okay, it does not cause that supraphysiological LH surge. Okay, and when you give this like this, when you give and have 2 or 3 follicles, there is no LH surge, believe me, with letrozole.
Okay, so do you do long protocol, like agonist protocol for IUIs in special situations?
No.
And dual trigger, you said you never use for IUI?
Never for IUI.
So what is your precautions to prevent multiple pregnancies? See, you are stimulating to get 3 to 4.
3 to 4, yeah. So in our hospital, we do have a twinning rate with IUI. And at the end of the year, when we calculate, the last year's data was we had a twinning rate of 5 to 6% with IUIs. Okay.
Okay. And what is the success rate in your setup? Like generally.
So the last year, the complete last financial year, the success rate in our hospital with IUI was 13%, 13. Okay. That is all patients, 13%, all patients put together. Last 5 years data success rate has been 14.1. But the reason why our success rates have gone down is because of the difficulty of patients whom we are adjusting for IUIs. Okay. Patients are really bad patients whom we are doing IUIs and still getting a decent enough success rate.
And in poor responders, do you use DHEA?
No.
Have you noticed increased risk of ectopic in your IUI cycles?
No.
Okay, I think, I think we have covered. So this freezing of the semen sample and thawing, so you think that can be done only if the DFI is good, or it can be done for all samples?
Absolutely, it can be done for everything. There is no doubt about that. But why I said is, when somebody has a high DFI, it is frequent masturbations is one of the treatment which works the best. Okay. In those people. So it is better to allow them to have a masturbation and then give an IUI sample.
Okay. Yeah, that was excellent. I think it's very, very good session. I thank you for taking this time out, for your commitment after doing such difficult cases in Hyderabad and then coming back and operating in Mumbai and still coming to do this webinar. I think, I think everybody is kind of like, overwhelmed with your energy and commitment. So very grateful to you. I thank all the people who have joined at this odd hour. So even if we announce at 12 o'clock, I think not less than 300 people will join us. So I request Dr. Jay to not go beyond 10 o'clock. Everybody has to sleep unlike him. So thank you very, very much for everyone. So we'll meet you tomorrow again with our next session.
Yeah, Kiran sir,